Chapter 6, Preparing for a Pediatric Spirometry Test. So in Chapter 6, we're going to do a quick review of the indications for spirometry in children, contraindications and potential complications and risks. We're going to run through what the ideal testing environment should look like. And then we're going to look at how to prepare the equipment and disposables, the child and the caregiver, the technician, and we're going to run through how to do the pre-spirometry screening questionnaires. So at the end of this chapter, you should be able to list the indications and contraindications for spirometry testing. You should be able to name and describe potential risks and complications to testing. You need to be able to describe how to prepare the environment, the child, the caregiver, the technician, the environment, and the equipment before the test. And then you would need to be able to conduct the 3 screening questionnaires that we have just mentioned. All right, so spirometry can be carried out on children in almost any setting. So some of the settings that I can think of off the top of my head would be in a lung function laboratory, in a research facility, in a primary healthcare clinic, in an outpatient clinic, in a ward, and even at home. So the child in any scenario, wherever they are, they should be made comfortable, and parents and caregivers should be invited to observe the spirometry test as well. When it comes to the age of the child to be tested, the guidelines suggest that children as young as 2.5 years old can be tested using spirometry, but every child should be assessed on an individual basis, and generally we start testing children around about the age of 5. This doesn't mean that younger kids can't be tested. They definitely can, but every child will be assessed individually. So some of the indications for spirometry, just a quick recap on that. For children specifically, we look to do spirometry to assess chronic cough and persistent wheezing in children and breathlessness, to diagnose and monitor asthma, or in post-infection lung disease, including TB, bronchiectasis, cystic fibrosis, restrictive lung diseases, and children born preterm with bronchopulmonary dysplasia. We also like to review the child's response to treatment decisions, especially those with chronic lung diseases. Monitoring in other diseases that may affect lung function but that are not necessarily lung diseases or respiratory diseases would be like the hematological disorders such as sickle cell anemia, thalassemia major, congenital or acquired immunodeficiency, that's HIV, hemato-oncology conditions, neuromuscular and connective tissue disorders, and chest wall deformities. Now, these diseases are not respiratory diseases, but either the medication that they're taking can cause an issue in the respiratory system, or the actual nature of the disease itself, such as chest wall abnormalities, can make breathing and respiration difficult for that child. We also use Spiro in kids to ascertain preoperative lung function, and sometimes school-going children are screened for respiratory disease. So some conditions may pose a relative danger to the child or affect the validity of the spirometry performance. And children who need spirometry but have potential contraindications maybe should be tested in a lung function laboratory or in a tertiary institution where there is emergency equipment available and maybe more experienced technicians should the need arise. So when it comes to contraindications for testing children specifically, let's look at them again in a little bit more detail than what we did in Chapter 1. So due to the increases in myocardial demand or changes in blood pressure, you need to be aware, be very careful of testing children who have had any recent cardiac surgery within 1 week. Any child with systemic hypo or severe hypertension, anyone with significant atrial or ventricular arrhythmias, anybody with non-compensated heart failure, anyone with uncontrolled pulmonary hypertension, acute cor pulmonale, any clinically unstable pulmonary embolism, or a history of syncope related to the FVC maneuver or with cough. In the second category, contraindications for children who have due to increases in intracranial and intraocular pressure would be things like children who have had a cerebral aneurysm or brain surgery within 4 weeks, or any recent concussion with continuing symptoms, or any eye surgery within 1 week. In the third category, due to the problems that arise with increase in sinus and middle ear pressures with spirometry, just be careful of testing children who have had sinus surgery or middle ear surgery within 4 weeks, or they've had an infection within 1 week. And lastly, due to the increases in intrathoracic and intra-abdominal pressure that can happen with spirometry, be careful of testing children who have a current pneumothorax or have had thoracic surgery within 4 weeks, abdominal surgery within 4 weeks, and in late stages of pregnancy, you might want to avoid spirometry testing. And remember, you've always got to weigh up how much you need the test versus the risk of that test to the child you're testing. There's one more category, and that is people with infection that could be passed on through spirometry to other patients or the technician. And that would be anyone with active or suspected transmissible respiratory diseases such as TB or even COVID-19. Other physical conditions predisposing to the transmission of infections such as hemoptysis, which is coughing up blood, excessive significant secretions, or oral lesions or oral bleeding. So as I said, the relative contraindications do not preclude that the test be done, but you just got to take all of it into consideration when deciding to go ahead and test that patient. Right, let's go on to preparing the environment for the spirometry test. A child-friendly environment is important for successful testing in kids. Encouragement, detailed but simple instructions, lack of intimidation, visual feedback while they're doing the test itself and in the teaching process is very important in helping the child to give you their very best maneuver. So testing should take place in a clean, bright, well-lit, well-ventilated and comfortable environment that is separated from the waiting room and other patients to be tested. So in other words, you want the child to be private. You don't want other people to be watching them. You need to make available drinking water, and you need also tissues in case they have secretions that they feel comfortable to cough into a tissue. Generally, there should be adequate space for the child, the caregiver, and the technician at least. Ideally, you will have a chair with arms and no wheels so that if the child gets dizzy when they're blowing, they can sit back into the chair. That will stop them from fainting or hitting their head on the floor or on anything around them. Good stable chair behind them when they're blowing, either to be seated in while they're blowing or to have behind them if they're standing while they're blowing is a good idea. For smaller children, a little kiddie chair or a footstool would be a good idea because at all times we want the child's feet to be on the floor so that they keep stable while they're blowing and they're not wobbling on a chair. There should be age-appropriate toys and reading material and art. Remember to take specific infection control procedures as we had already discussed. So the room has got to be well ventilated, clean. You need to have your hand washing facilities available, gloves, masks, disposable mouthpieces, and filters and biohazardous waste to throw the used mouthpieces into. So we also know, as we've already discussed, that temperature is an important variable in spirometry, depending on the type of spirometer used, and that it's the responsibility of the technician to ensure that the testing environment is within the ambient conditions allowed at the time of testing. Now we need to prepare the spirometer. So remember that in terms of preparing the spirometer, we've already done that when we did a linearity calibration check on the day before testing, or if the temperature has changed by more than 3 degrees in 30 minutes. You need to have biological control if your workplace has decided to do that. Remember that biological control is recommended, but it's not mandatory. Additionally, your calibration syringe should be in good working order. You should have all your disposables available. So as I said, your mouthpieces, filters, all of those things. You need to have a stadiometer, proper stadiometer for measuring height correctly. You need to have a weight scale, a weather meter, your syringe. And for bronchodilator testing, you would need to have available either your meter dose inhaler and spacer or a nebulizer device as well. In terms of technician preparation, the technicians must be trained and competent. So they need to hold a certificate in foundational pediatric spirometry, and they need to have had regular refreshers. So in terms of preparing the child then, you want the child as relaxed as possible. So when they come in, they have a few minutes to rest as they come in, and during that time, you can then conduct the respiratory symptom screening questionnaire, the infection control risk questionnaire, and the contraindications questionnaire. And I'm going to show you how to do that shortly in a practical demonstration. Right, when you've done all your questionnaires and you are absolutely sure that there's no infection risk, that there's no contraindications to testing, we can go ahead and start entering the subject data into the spirometer. So the major determinants of spirometric lung function is age, height, gender, and race. So you need to correctly record those things into the spirometer. So when taking a height, it's very, very important that you take the height as accurately as possible and that you enter the exact measurement of height into the spirometer. So in other words, don't measure the patient as 143 centimeters and enter them as 140 centimeters into the spirometer. That's going to give you incorrect predicted values. So when you are recording height, it should be done in the Frankfurt positioning, and I'm going to demonstrate that to you now. So did you see how the child's back was flush against the wall, head upright, chin at a 90-degree angle to the body, eyes looking straight forward, and the stadiometer is brought down onto the child's head? Right, when you measure and enter the height, it should be within 0.1 centimeter for accuracy. And remember that if the child has an abnormality or a deformity and you can't take the height correctly, you would take the ulnar length. Okay, so the preferred secondary measurement, if height cannot be measured in children, is to measure the ulnar length, or alternatively, you could measure the arm span. Fingertip to fingertip, that is an approximation of the child's height. So when it comes to weight, the child should be weighed on a scale without the shoes on and with indoor clothing. So no heavy jackets, no cell phones in the pocket or anything like that. You need to record and measure the weight within 0.5 kilograms. And the body mass index in your spirometer should be calculated and shown as kgs per meter squared. It is preferable to calculate the age of the child using the date of birth and the date of the test. Age should be reported in years to 1 decimal place, and hopefully your spirometry software can do that. So now some of the activities that need to be avoided before spirometry testing so that the end result is correct are these 4 things. And a lot of these apply to the older children, but we have to pay attention to this. So the child should not have smoked or vaped or taken a water pipe within at least 1 hour prior to testing, because if they do this, it can cause acute bronchoconstriction due to smoke inhalation. The second thing is that they should not have consumed any intoxicants within 8 hours before testing. So that would be to avoid problems with coordination, comprehension, and the whole physical activity and the effort required to actually undertake the blow. So no marijuana, nothing like that. Performing vigorous exercise 1 hour before testing can cause the child to have an acute exercise-induced bronchoconstriction, so we would prefer no exercise within an hour of testing. And wearing clothing that substantially restricts full chest and abdominal expansion can lead you to have restrictive-looking spirometry. If the lungs can't expand as they should due to tight clothing, you can have a restrictive result, which would be a false result, obviously. So they need to make sure that they've avoided those 4 things. Just to recap, smoking, vaping, and a water pipe within 1 hour, intoxicants within 8 hours, excessive exercise within 1 hour, and no restrictive clothing at the time of testing. Now, the decision to withhold medication is a clinical one, depending on the reason why the child is being tested. And the decision of whether or not to stop taking medication on the day of the spirometry test needs to be documented in the standard operating procedures and then referred to by the spirometrist prior to testing. So those instructions for withholding medication obviously have to be given to the child before the day that they come for testing, so that they know what to do on the day. In general, short-acting bronchodilators are usually not taken for 4 to 6 hours prior to a test, and long-acting bronchodilators for 12 to 14 hours prior to a test. Because obviously if they've taken that medication, it's going to maybe give you a false positive spirometry test result. But if medication has been taken on the day of testing, the technician needs to record the name, the dosage, the time that the medication was taken, so that the person who is interpreting that test or picking up the test at a later date knows exactly what happened. That brings us to the end of the chapter on preparation, and I'm quickly going to go through a few fun did you knows. So, did you know? If an error is made when entering subject details or the reference values into the spirometer, the predicted values and the lower level of normal will be incorrect, leading to incorrect Z-scores and percentages of predicted, which may lead to incorrect interpretation, which may lead to an incorrect diagnosis and treatment. So I reiterate again how important it is to enter your subject details absolutely accurately into the spirometer before you begin. Thank you very much. We'll go shortly on to Chapter 7.